Mike has been one of our partners who every year will give us our IRB certification 2-hour lecture on medical ethics and in research. But he's been nice enough to try to pare this down and to modify it enough to give us a talk. And in addition, we have John Burleson, one of our fellows who just graduated, who will also be giving a portion of this talk. So Mike, we thank you for all the time I know you put into this talk, and thank you for doing this. And John, thank you. And we know that you're just starting out there in Nashville. So take it away. We look forward to a good next hour.
Well, thanks for the introduction, Rick, and thanks to the Seattle Science Foundation for facilitating these meetings. They've been great. As Rick said, I'm going to talk about some ethical things, and I know that's usually fairly dry. So if I can take control of the screen, I think it did. First, I'm going to start with disclosures. I do receive some royalties for some implants, and we're going to talk about that a little bit in this talk. And I do have interests in hospitals and ambulatory surgery centers. And I have had, but I don't currently have interest in a neuromonitoring company. And some of the slides have been borrowed, some from the government, and the government gave me permission to do them, and one from Sig Bervin, and I'll disclose that when I get there. We might be double dipping a little bit, meaning that we might be getting some ethics and also getting your ethics CMEs and getting your regular CMEs and maybe doing some best clinical practice training at the same time, which is sort of nice. Hi, Sig. And we might be calling some babies ugly. I may be stepping on some toes, talking about some things that people do, and that's okay. It's good to get an open discussion about it and figure out where we can have some commonalities and how we can do the best things for our patients. So the top 10 ethics topics that are taught to medical students are recommended by the AMA to talk to students are listed here, and I'm not going to read them to you. I'm going to be reading plenty of slides tonight. But one of them is management of conflicts of interest, and I'm going to be spending a fair amount of time on that. I'm going to start, though, with a little example or a case study of protecting human studies and research and some of the rules and why they exist. I'm not going to be exhaustive about it. I get exhaustive in that 2-hour talk that Rick talked about, but we're just going to hit a few of the highlights, and then I'll give an overview of good clinical practices for research. And then I do have a pet peeve about data presentation that I'm going to review with you guys and see what you think about that. And then I'm going to spend hopefully a fair amount of time talking about times when patients' best interests don't necessarily align with the surgeons and how we can manage those conflicts and how we may not even be realizing we're in those conflicts, but we have to respond to them. The historical thing I wanted to talk about, and this is a case example of a study gone incredibly wrong, is the Tuskegee syphilis study. Maybe the most notorious example of a study that was unethically performed in the United States with definite violations of rights and welfare of the patients involved in the study. It was basically a natural history study of untreated syphilis, started in 1930s and continued actually until 1972. So I was very much alive, very much in the education system by then, and I didn't even realize this was going on. It involved about 600 African-American men, and only African-Americans enrolled. 400 of them had diagnosed syphilis, and 400 did not have syphilis, and they were recruited to be followed longitudinally without any consent. And they were led to believe that some of the tests that were given to them, the spinal taps and x-rays and that sort of thing, physical exams, were special free treatments that they were getting, but really all they were doing is taking data from those patients. Well, very early on in the study, it was apparent that more of the infected people than the uninfected people were dying and developing complications, and the death rate was already markedly higher. And in the 1940s, penicillin was found to be effective in the treatment of syphilis. Nevertheless, because these patients were in the study, they were not given syphilis. And throughout this time, this is how we know about tertiary syphilis. This is how we know about Al Capone dying of syphilis, because we have seen longitudinal data on it. But these patients were not aware of what was going on with them. They were not informed about their treatment. They were not treated with antibiotics. So following that, several things came out of it. There was a national press account of it in 1972, which really kind of shut the whole thing down, and the Department of Health and Human Services got involved, and they created a couple things. One is the National Research Act of 1974. There's an HHS policy document on the protection of human subjects, and the National Commission for the Protection of Human Subjects in Biomechanical and Behavioral Research was initiated. So a lot came out of it, but it was pretty bad. One of the other things that came out of it was the Belmont report, and I'm not going to go into the weeds on this either, but the three basic principles that were developed out of the Belmont report were respect for persons and individuals, beneficence, and justice, meaning this study was a perfect example of injustice, meaning that patients not expected to benefit from the results of the study were exposed to the study. You have to give an equal amount of risk to the patients who are going to benefit from the study. So that's the foundation of the current HHS principles for treatment of human subjects. I'm going to talk a little bit now about best clinical practices, or GCP's, good clinical practice. It's an international ethical and scientific standard designed to help us conduct and report trials in an ethical manner. The current system of good clinical practices has responded in part to things like the study I just talked about, the Tuskegee syphilis study, and also the the war crimes of Nazi Germany. And there's a multiple criminal or unethical research that was done in the past, and we're trying to not repeat those errors. The GCP guidelines provide a framework for fair and scientifically sound conduct of research studies that involve human subjects. So all trials that we participate in, any that receive federal funding, and essentially any that we get in contact with, are conducted according to good clinical practices. So we all need to be trained on this, and we do have an official training at our practice. And when you're going to see these slides, there's a test at the end of it, and the talk goes very fast. So most of the test answers are the things in blue. So if you see, why did he highlight that? Well, that's kind of helping the people along with the other testing if they needed to do it. So what we need to know about this is, yes, we've got the federal guidelines, but sometimes state and local guidelines can be more stringent. And if that's the case, we need to comply with both the federal guidelines and the local guidelines, or if we're doing an international study in that other country. So all of those other guidelines need to be respected. One of the things GCP's mandates is that we have an institutional review board. That can be something that lives in the hospital or something that is contracted from outside the hospital and reviews the studies from outside. And the purpose of the GCP, or the IRB, is to safeguard the rights, safety, and well-being of the human subjects. Any clinical investigation involving products regulated by the FDA must be reviewed and approved by the IRB, and any study that involves something that the federal government is funding has to be reviewed by an IRB. But at our institution, essentially anything we do is reviewed by an IRB, and even if the IRB doesn't get involved because of exceptions that allow a waiver, they've at least had a look at the study from the beginning. The IRBs will have authority to approve or disapprove of the research activities, and the IRBs will periodically, and at least annually, review the studies and look at the protocols, make sure everything's being done on the up and up, at least annually. One of the things also that is dictated is that we get informed consent. Obviously, in the syphilis study we talked about before, there was no informed consent given to the patients. Well, informed consent is a process by which the patient is informed about the study and voluntarily agrees to participate. And I say process, meaning that is an ongoing thing. So if something changes about the study, or if the patient changes their mind about participating in it, we need to be able to continually evolve that. So it's not an event. We think of consent for surgery as an event. They sign the form and they're good to go. Consent for research isn't exactly that. It's an ongoing thing, especially if we're doing longitudinal studies following the patients over time. Consent documents need to be written in a form that the patients can understand. So if the patient's group is expected to be from multiple languages, we need to have the forms in multiple languages. If the patients are very young or poorly educated, then we need to have the forms written in whatever education we expect them to have. We can use children as research studies subjects, but they're considered a special group that requires special protections. Their parents can consent for them, but the child needs to what they call assent, meaning they're saying it's okay. They cannot consent for themselves, but they can assent before enrollment in the study. And we can't coerce patients. We can't tell them, well, we're not going to treat you if you don't get involved in this study. The participation in the study has to be voluntarily and not unduly influenced. We can pay them to be in the study. We can't pay them to come back for visits, but it can't be so much that it coerces them. It's so you have to base that payment on their income status and how much they might be influenced by the payment. We also have to maintain confidentiality of the information we obtain from the study, or de-identify it when we're disseminating it, if we do disseminate it. There are exceptions in times when we can release information. We can release it to medical personnel in an emergency. In fact, there's a whole long list, and I'm not actually going to read that whole list to you. We all know about the HIPAA privacy rules that protect all patient identifiable information, and so we know that when we disseminate information, unless we're have an agreement with who we're releasing information to, the information needs to be de-identified or grouped in some fashion so that we can legally and ethically disseminate it. So also we have to report, we're responsible to report adverse events. An adverse event is defined as an untoward medical occurrence in a person who receives a drug or device while participating in the study doesn't need to be related to the study. In fact, we have a saying at Texas Back that the study is not even going until we have our first spider bite adverse event. It's just something that happens, and it's you know, we've got to document all of them. It's not like we can't let our egos get involved as surgeons. You know, like, I don't get complications. I don't have that many complications. Adverse event does not mean you had a complication. What it means is something happened that we need to document. And if it turns out that every patient that gets, you know, your artificial disc gets a spider bite or something like that, maybe there is something about the device that attracts the spider. So they're just collating data. Serious adverse events are events that need to be reported on an urgent basis to the sponsor and sometimes to the FDA if it's an FDA study, or if it's a study that may be eventually reported to the FDA. So usually within 24 hours, immediately is what they say, but within 24 hours usually satisfies. Quality assurance, every study is going to have a quality assurance person, usually somebody external and somebody internal that maintains quality. Those quality assurance people will do periodic audits, and but the quality maintenance is a responsibility of everybody who's in the research project. It's just that that one person is responsible for collating it and reporting back on it. And we want to make sure that these trials are being conducted in compliance with the currently approved protocols, as well as good clinical practices and other applicable regulatory requirements. Can I go forward? One of the keys to any research project is a very solid protocol. You have to define what's going to happen in the study. We need to make sure that the protocol dictates a standardized set of data that's obtained and procedures that are done. Because if you don't collect the data in a standardized manner, you're not going to have usable data, and therefore you're exposing the patient to potential risk without a reasonable reward, a just reward. Also with the research protocols, if there is a change in the protocol, it's called an amendment, and that has to be circulated to the IRB, and again, back to the FDA if it's one of those studies that's an IDE, that meaning the product is going to be referred to the federal government for approval, or if it's something that the federal government is funding. Research misconduct, and this is something that they're very stringent on. We obviously try to avoid that. Research misconduct is basically fabrication, falsification, or plagiarism in performing or reviewing research on reporting the research results. This definition, of course, doesn't include honest error or differences of opinion or even authorship disputes, unless those authorship disputes really are plagiarism. Then it does get into the weeds on that. Non-compliance with policies and procedures for the protection of human research subjects is reportable to the IRB, but it may not be considered a research misconduct under this federal definition. So I'm going to talk to you a little bit about, this is my pet peeves section, and I'm going to talk to you a little bit about honestly and ethically reporting data. You know, I was trained as an engineer, so went to medical school after that. So I was very much involved in, you know, my physics class, learning how to report data. And data should be presented in a way that accurately and honestly reflects the results with the certainty to which those results are known. And I looked at a paper recently. I do review papers for a few journals, and when I looked at one paper recently, I know it said that the estimated blood loss in some subgroup, and it's not critical which, but a subgroup was 2,023.9 plus or minus 1,300.4. which implies, when you look at those numbers, that we know the blood loss to a very high degree of certainty and with great precision. But we all know as surgeons that when we're getting that blood loss, it's a back of the envelope estimate. We're looking at the blood in a cylinder. We're trying to estimate how much blood might be on sponges and how much came out of the cell saver, that sort of thing. So it's a very gross estimate. So to imply that you have this degree of certainty is not really communicating the accuracy that you really know the data. And at the same time, this data implies that there is a wide range of uncertainty about the average, 1,300 cc's or more. And so to say that we're talking about that 0.9 cc's, 9/10 of a cc, and the precision is not sensible. Does it make sense to talk about that tenths of a milliliter? It's an easy trap to fall into because the software we use, the calculators we use, the SPSS statistics software will spit out these numbers to very high precision, and it looks like you're doing good work to report all these long distance numbers, but you need to make sure you're getting something that makes sense and that you're communicating what you really know about the data, not what the calculator knows. Because the calculator doesn't know what you know about how accurate the data is. So are there rules to decide how to present this data? This is this error analysis book by John Taylor is a reference that I've used since my freshman year in college, and it's really quite excellent in terms of how do you report errors and how do you manage error analysis. This other book, Proofiness, is more about how you can use numbers and statistics to make a point that maybe the numbers don't make for you, and you're using them in somewhat dishonest manner. So both are good references. I would say the error analysis book is quite dry, but really good. And somebody on your research staff, hopefully a statistician, should look at this and know the stuff in this. Maybe you don't have to know it every time. So I'm going to use a simple example that I made up, and I made it up for a particular reason to make a few points. So if I looked at what the average blood loss is in a discectomy, say you did 7 cases and got blood losses of each case as I show up there, but anywhere between 10 and 75 cc's. Well, I average those numbers, and those numbers come out to 32.14286 milliliters, which we know that I measured those to no more accurately than 5 cc's, and I'm still looking at a number that's very, very high. And then I looked at the standard deviation, which I got right out of my Excel spreadsheet on my laptop, and it gave me a standard deviation of 22.70410. That means that the true average of a very small data set is going to lie somewhere in between that, and with a 95% confidence. Now, we use standard deviations to represent a 95% confidence interval very commonly. That's not actually correct, but I know that we do it all the time. So give me a pass on that. I know it's not exactly statistically correct. It assumes some things about distribution of the data that has not been shown with this, but we do use it all the time in that way. So it just means that the number is somewhere between these numbers, and I'm not going to read them to you, but somewhere between the high number and the low number, or 32.142 plus or minus 22 point lots of numbers. So again, I put a whole lot of numbers there, and I made it the number that I divided by 7, so it would generate a whole lot of numbers on purpose to demonstrate that you can create these numbers that give you a lot of false precision without having real information associated with them. So again, looks very precise. Rule number 1 for presenting uncertainties is your uncertainty. Everything past the plus minus has 1 digit only, unless that first digit is a 1, sometimes a 2. So if you use that rule, that you'll keep yourself within what's considered standard, what's considered normal in reporting data. And I know we do it all the time, presenting these large numbers, but it doesn't make sense in terms of what you really know. So in this case, it would be 30 plus or minus 23 milliliters. And you don't put a trailing 0 because that 0.0 actually implies that you know something about that last number as well. You do put a 0 before the decimal point to be very clear, but after the decimal point, if you put a 0.0, it implies you really know something about that number, and you really don't. So no trailing 0.0. Rule number 2 is the answer, the big data point, that 32 number. The last significant figure should be the same as the decimal point as the last decimal point in the uncertainty. So the 32.14, that 0.14 just goes away. That doesn't tell you anything. So the real way to present this is 32 plus or minus 23 milliliters. And it would also be appropriate to present it as 30 plus or minus 20, because I told you that the 2 decimal place, if you 2 as your first digit, you can round it or not round it. Both are considered acceptable. I tend to, with 2s, round the last digit. So the 23 is how I would normally present this. So very different than that long number that we saw before. So back to the original example, I started with that. I'm going to call it a case because this is a case conference, where we looked at the average estimated blood loss in that subgroup we talked about. And we had this very large number, many more significant figures than was appropriate. But if we use rule 1 and look at the uncertainty, we can see that the uncertainty really comes down to plus or minus 1,300 milliliters, not something point anything. It's 1,300 milliliters rounded out. And then knowing what the significant figures are, which is the first 2 digits, we changed the average of the blood loss down to 2,000. So 2,000 plus or minus 1,300 is the appropriate way to express that data, communicating the range of the data and how well you really know it. You can have a number that has 8 significant figures if your plus or minus is not including those 8 significant figures. Your uncertainty doesn't mean it has to be a 2-digit number. It can be a very large number, but the uncertainty and the answer, the number that you're trying to communicate, need to have similar ranges of precision. So this really accurately reflects the precision that the data is known. And this is just the picture shows how we're getting that estimated blood loss measurement. It's very crude. From the same paper, we I looked at their PILL mismatch, and they said at baseline, I'm not going to talk about all the numbers in this paper, and I did like this paper and thought it was going to be something that we would accept, but I wanted them to clean up their numbers. The PILL mismatch at baseline was 22 plus or minus, sorry, 22.612 plus or minus 17.363 degrees, which we know that when we're measuring these angles off the PAXs or off our x-rays, we can measure and agree with each other within about 2 or 3 degrees. Well, they're reporting data to the thousandth of a degree. And that's, it doesn't make any sense. It is not sensible to report data to that degree. So using the same rules, the PIL mismatch should have been reported as 22 plus or minus 17 degrees. And that gives you an idea of how accurately they knew the numbers and what the range of error is. And really, just to get nerdy, if their error if it had been a close group of data that didn't have an average that was wide, like that set plus or minus 17, if it came down to a number that was plus or minus, say, 1, we also know that the error in the measurements was, say, plus or minus 2. And since PIL mismatch is calculated, when you calculate a number based on 2 numbers that each have an error, you have to add the uncertainties. If it's an addition or subtraction, you still add. And so it would have been plus or minus something like 4. But that's a nerdy detail that I don't think any of us need to know, but your statistician might need to know it if you hit that circumstance. We did have an interesting thing pop up as I was doing these slides, and I was watching last Friday's talk. I found out that even the best of us can fall into this trap. This is a screen capture from last Friday where they talked about the savings in ambulatory surgery center outpatient department, and you see the Medicare Advantage numbers is $5,814 plus or minus $7,693. So that's a big range with very precise looking numbers. And as I said, easy trap to fall into. Dollars can be measured with great precision. There's no doubt about that. But you lose that precision where you start averaging numbers that, though very precise on their own, are far ranging and have a wide amount of difference. When you say you have an uncertainty that's greater than the value you're measuring, it implies that there are some cases in the Gaussian distribution that might be below 5,184. I don't think there are any cases where the surgery center paid the insurer to do the operation. So I don't think that plus or minus is reflecting what really happened. And in fact, we can infer from looking at that number that it was probably not a Gaussian distribution. That's why I put that non-Gaussian curve up there. It's probably something like that. Not the Gaussian distribution you see on top, but more like the non-Gaussian distribution you see on the bottom. So if I were presenting this data, I would have said something like 5,000 plus or minus 800, and that's probably what I would have done. But you could also say $5,000, 95% chance it's less than $1,300, not giving anything about the bottom of the range. So there's lots of ways to present this data, but I think just having lots of numbers makes it seem more precise than it probably is. You can also present the median in a case like this, where so you're going to have a median and an average. And in this case, with a non-Gaussian distribution, you're going to have the median that's lower than the average. And that median number is very appropriate to present with as many significant figures as you want because it's an exact number. So lots to think about on this, but just try to make sure your significant figures make sense. Now I'm going to get into what I think thought was going to be the meat of this. I'm going to talk about alignment of incentives and what's good for us and good for our patients. And it's always better when these go together, and it's not healthy when those are put in opposition. And I think it's one of those don't hate the player, hate the game kind of situations. The game is what it is. We're paid how we're paid for what we do, and it would be better if those incentives were aligned, but it's not always the case. And I'm going to kind of bring out a few situations where I think that's the case. We're going to do that with some cases. Of course, one of the first duties of a doctor and one of our ethical responsibilities is to prioritize what's best for our patients. But even when that's done, we prioritize what's best for them. There are sometimes situations where there are arguably equal alternatives we can offer to the patient that have different rewards for the surgeon, both monetary and other rewards that are a little more subtle. And I'll try and draw out some of those and try and give you a way to think about those that the way I've been thinking about it, and we'll see if it helps anybody. So I'll start with some examples of things that might be putting people in conflict with their patients potentially. Is physician ownership of ancillaries unethical? And I would say, no, it's not implicitly unethical. It's something that is actually very reasonable to do, but it does at minimum put you in a situation where the conflict might require management. So you may need to disclose to the patient that you're an owner in a facility or owner in an ancillary, and make sure that you don't overutilize or refer to a patient to a particular service that is not appropriate for them because you're the owner. There is a specific type of ancillary called a pod that was proliferating and actually still exists quite a bit, although they don't identify themselves as pods. But they're out there, and the OIG came out with an opinion statement, a special fraud alert they released in 2013, saying that they believe that pods are inherently suspect under the anti-kickback statute. So it's something that needs to be managed. Concerns and things that put you at risk if you're part of a pod is if the size of your investment or the size of your return varies by the amount of utilization you have of that pod. That somebody that refers to the pod a lot gets more money from their referrals, or is allowed to buy more shares, or has a different price for buying the shares. There's all kinds of ways you can unfairly do it, and that puts you at conflict, and that makes that not inside a safe harbor and not compliant. If you refuse to do procedures at a facility that won't utilize your pod, that's potentially a conflict. And if you don't disclose your interest to patients, that can potentially be an unmanaged conflict. We had a pod, and we called it North Texas Surgical Services, and we fully disclosed it to our patients. We fully disclosed it to the facilities where we used it in, and we delivered the same implants, the same quality, in fact, the same brands of implant that we were able to use before, but we were able to buy them in bulk and not have to pay a percentage. What we would do is pay a salary to the rep or the person who was maintaining the implants in the operating room. They weren't exactly a rep anymore, but they were our salaried employee. And it did not result in a change in our utilization. We kept, most of us, all of us in the practice kept using the implants we like to use. The owners of the pod were not required to use the implants. So it was, by all those measures, compliant. Nevertheless, with that OIG statement in 2013, our pod was shut down because of the hospital system's response to that OIG opinion. So that pod went away, but not all pods went away. There are Texas pods that still exist, and there have been examples of, and this is just from second opinions and times I've seen patients treated by other practices, and they've come to me, they have resulted in overutilization. I've seen things like the ladder construct that I've got in this picture that's got 5 crosslinks in it. And this is somebody who owns the implant company and is potentially motivated. I've also seen cases where you put 2 T-lift cages in an interbody fusion rather than using 2 PLIF cages, which are priced at half the price of a T-lift cage. They use 2 T-lift cages. So, not necessarily on the up and up, and certainly buffing the billing for the pod. I do think a lot of these pods continue to function because they're not disclosed to the hospitals, and the hospital systems really have no clue how to identify a pod. They identify a pod by us telling them, yes, we had a pod. They're missing the obvious ones, and they have concluded that some of the companies that have physician investments are pods, so they don't allow use of those implants. Like, for instance, at our facilities, we weren't able to use Titan implants while that was an independent company because one of the founders is a doctor, though not practicing. By the end of all this, he kept it from being used. He's a doctor in Wisconsin or Chicago, and kept us from being able to use the implants in Texas because it had physician ownership. So they're really missing the forest for the trees. Hospitals, in our neighborhood at least, don't know how to identify a pod. Some of the pods have also consolidated into super pods to further hide their ownership, and that's just another way around it. Other forms of interest in implants, you can buy and repackage or rebrand implants from manufacturers. You can do a stock and bill where you buy implants in some quantities and then provide the same implants with different part numbers for different insurers, which is Medicare fraud if you get caught and one of those insurers is Medicare. But that's being done. Royalties are very common arrangements, and since we have a very esteemed group of faculty here, I'm sure many of us, I've disclosed at the beginning, I have some royalties on products. This is one of them. And those need to be managed, and as long as you don't overutilize the implant because you're being motivated by finances to do it, or your partners do it to try and buff your income, as long as those things aren't happening and you can manage that, that's okay. It's okay to own, or at least I think so. I do it. It's okay to have royalties. In the case of the contracts that we have at Texas Back, if you have a royalty agreement, that royalty needs to exclude any implants that are done at any facility where any of our partners have privileges. So therefore, none of us are motivated to use products to line each other's pockets. We're using the products because we like the products and we think they're the best option for the patient. And that's the way you should make your decisions. Ambulatory surgery and hospital investments. Now, I know that the Denver group from Mike Jansen discussed this a couple weeks ago, and you got a lot of detail on that. But I just want to talk about a few just potential conflicts and ways around them. The ambulatory surgery centers operate under safe harbor guidelines. They're not considered to be a designated health service, so they're not responsive or responsible to the Stark laws, but they are responsible to the federal anti-kickback statutes. And this is not from the verbiage of the anti-kickback statutes. This is sort of a lawyer summary of them, but it requires in part that each physician investor be in a position to refer patients to the ASC and perform surgery on such patients. So the ambulatory surgery center can't be owned by physicians who are passive investors, so that they're thinking that those investors might be referring patients to the investors to make money. The people practicing in those facilities need to derive at least 1/3 of their income, their medical practice income, for procedures they perform at the ASC. So one of the 1/3 rules, but the other 1/3 rule is at least 1/3 of the procedures that they perform can be performed in an ASC setting that you're invested in, if it's a multi-specialty ASC. It's a little bit different if your ASC is just a one specialty ASC, but I think most of the ones that I know about are multi-specialty. So a few rules on ASC investments. On the hospital side, we do get into the Stark laws, and the Stark law has an exception known as the whole hospital exception that permits a physician to refer his Medicare or Medicaid patients to provide any of 11 designated healthcare services to a hospital to which he has ownership, if the referring physician is authorized to perform services at that hospital, and it's not just a distinct part of the hospital itself. So I can't own part of the hospital. I can't own just the radiation part of the radiology part. I can't own just the OR part of the hospital. I have to own the whole hospital to be compliant in that. There are a whole laundry list of rules to test compliance in the Stark laws, and referrals to the hospital need to be appropriate. They need to be patients that are appropriately at that hospital. And in general, we assure that by making sure that the hospitals we invest in, and I think everybody does this, are the best places to take care of the patients. They have the highest satisfaction rates, the highest safety, and that the costs are not unduly burdensome to the patient. So if you're doing the out-of-network thing, that gets you into a compliance risk. So I think a lot of those out-of-network plays tend to not take federal payers to try and avoid having to be compliant with the Stark laws. We do have, since this is a case study, I'm going to give you a Dallas case, and this is a recent court finding of 4 doctors who were convicted, 3 spine surgeons actually, and 1 pain management doctor, so very relevant to what we do. They were convicted under the Federal Travel Act of accepting bribes and kickbacks in exchange for referrals. They're all awaiting sentencing now, but their sentencing guidelines could be anything up to 5 years in prison, so are in federal prison, and that's a fairly big deal. So just keep your compliance very transparent. I'm going to turn it over to John, who's going to talk us a little bit about intraoperative neuromonitoring and how that potential conflict can be managed.
Thank you. Let's see. Can I control this? Awesome. So, like Dr. Hisey said, I'm mainly going to talk about neuromonitoring here. We're not going to dive down deep into details. I really just want to bring up the larger points of another potential conflict of interest and ethically some of the issues I think we should be thinking about. So we're going to talk about how prevalent is neuromonitoring. Is it actually helpful? What are the ethics behind it? Some billing issues that you've probably all heard about or experienced, potential conflicts of interest, and appropriateness of neuromonitoring in general. So first, this paper's from 2014, but I thought this was an important demonstration. From 443,000 surgeries over a 4-year period of time that they looked at, just the prevalence of neuromonitoring across the United States. They saw in 2007, 1% of the cases were neuromonitored, and in 2011, 11%. So over 4 years, pretty dramatic increase there in usage overall. And then the next two lines, you can see that there's some regional differences in neuromonitoring utilization. At the end of this study here, they were looking at 8% of cases in the Northeast were neuromonitored, whereas 21% in the Midwest. Other regions of the country fell somewhere between those, but there's certainly a little bit of a regional bias in terms of intraoperative neuromonitoring utilization. They didn't find, looking at this, any change in neuroinjury intraoperatively, although we all know this type of study is not really designed to look at that, but they threw that tidbit in there. So broadly, for like 45 seconds, I'm going to show you two examples of different types of scenarios. So one of them, a cervical case here. This study just kind of looked at 26,000 cases for ACDFs and corpectomies. They were really looking at whether you neuromonitored or didn't neuromonitor, did it change the rate of nerve injury? And what they found is it didn't, that they could find, but the rates were really low. 1% for corpectomy, 0.2% for an ACDF. So potentially not powered enough to determine a difference, but what they were showing, what they were trying to get at here is that maybe some types of cases with a low enough injury rate might not necessarily benefit from neuromonitoring. This is all comers. It's not talking about myelopathy or anything in particular, but that's one of the points they wanted to demonstrate. On kind of the other end of the spectrum, when we talk about metastatic tumor surgery, this paper here is just one institution, 128 patients, and you can see their Asia classifications there. They had 13 what they call true positive events in the operating room, where the tech raises their hand and says, I got this problem. 7 times it was during a decompression. The surgeon finished the decompression, things went back to normal. 5 times it's during instrumentation, in which case they stopped, they put in a different implant or took out that screw or put in a different rod. They did something different and things went back to normal. 1 time it was during a lateral approach, in which case they stopped, kind of went through a different plane, started up again, and things went back to normal. In 114 cases, the tech said everything was fine and everything was fine. And in 1 case, they said everything was fine and everything was not fine. The important thing here, although that 1 case is kind of interesting, the thing that's important to me, or the takeaway for me, is 7 times there was a time that neuromonitoring went off and we didn't change what we were doing, right? We just continued the decompression. So you could argue it does give you confirmation after the case that things returned to normal, which is great, but it didn't ultimately change what the surgeon did. And had they not neuromonitored, the outcome is probably the exact same. The other ones with the instrumentation, if they had neuromonitoring there and decided not to listen to the neuromonitoring, or if they didn't have neuromonitoring and obviously didn't change what they were doing, maybe things come back or maybe they don't. So it's potential that those 5 cases, neuromonitoring helped us make a better decision for the patient, which is obviously why we neuromonitor cases, to give us information we can act on to do something different. So those kinds are, you know, and then deformity obviously and myelopathy are things that are very commonly monitored for the reason that I demonstrated in the tumor one. In this case, bigger paper, 2010, really just looking at, like, does it make sense to neuromonitor? Big picture. They looked at a ton of information out there, whittled it down to 32 really strong papers. What they came up with is this: high evidence that says neuromonitoring is sensitive and specific for intraoperative neurological injury. Great. There's some good evidence that shows that it can reduce the rate of new injuries, and that intraoperative response of the surgeon to an alert can ultimately reduce the rate of neurologic deterioration. So their recommendation, big bold red at the bottom, it's recommended that the use of neuromonitoring is considered in spine surgery where the cord or the nerves might be at risk. So I see that and I think, great, we should use it on every case where the nerve or the spinal cord's at risk, which is like almost every spine surgery case, there's a nerve somewhere involved. And then, you know, you get through medical school and you start getting Beckers and all this other stuff. And you see these kind of scary things. And one of them is like this is News 9. I don't even know where this is, but you see, oh, a surgeon who's a part owner in a neuromonitoring group is sued because a patient got billed $100,000 for a neuromonitoring procedure that typically costs $1,000, you know, and it's this big deal. And then there's this, which is where I'm at in Tennessee. This was Inspector General dealing with a $1.9 million settlement for fraud for neuromonitoring. So then it makes you want to take a step back. Okay, well, how do I know what's the difference between this, what I'm seeing, and what I think is good for the patient? I want to make sure I align my incentives with the patients, but I also want to make sure that, I mean, in all honesty, if someone's getting paid for these services that I'm facilitating, like maybe it should be me and not some trans-Canadian holding company, you know? And so these are the types of issues that kind of got me interested in looking at how this works. So it turns out there's a society called the American Society for Neurophysiologic Monitoring. I went to their website, stole this logo from them. They had a picture of their last annual meeting, not exactly people you want to have a beer with, but it looks like they're having a good time. And this is one of the first things they say at the top is they're talking about some neuromonitoring groups related to like that first article where they bill $100,000, where they say some groups charge excessive fees in order to gain business through the surgeon by then paying the surgeon money on the back end. So that's a kickback. You pay money on the back end for a fee proportional to, you know, the business or an agreed upon rate. It's a kickback. But there's a lot of other models in existence that get confused for that. Other models like having a company that is partially owned by the physician, partially owned by the neuromonitoring company, by which the money that comes in pays for the tech, pays for the neurologist, the money left over is split between the owners. One of the owners happens to be the surgeon. And there's a lot of debate about that I won't dive into, but there's a lot of different ways this can be structured. So the AMA kind of weighed in on some of this stuff too, and I won't read this verbatim, but their code of ethics has a lot of stuff that we all understand to be true. Like you should do what's right for the patient. You should pay attention first to their needs, not to your own financial needs. And all of this stuff makes perfect sense. Everyone here agrees with this. The patient's the most important. My finances are part of what I do, but they do not drive the decisions behind what I do. The problem is, even though we all think that, I'll show you some examples where that's not necessarily the case. So balanced billing, I'm going to give you 30 seconds on this, is one of the problems behind neuromonitoring. And the reason is because neuromonitoring is almost always out of network. I've heard of some that are in network, but by and large, they're out of network. So when that happens, they bill the insurance company, typically the deductibles met, so they're billing the insurance company a whatever number they want to bill. The insurance company sends a notice to the patient that says, hey, we got billed $40,000. We're going to pay $2,000. You might get a bill for $38,000. Sometimes they pay $2,000, sometimes they pay $30,000, sometimes they pay $200. It's totally random. I don't really understand any of it. I'm sure there's some people out there that do, but they pay what they're going to pay. Then that neuromonitoring company might bill the patient the remainder. That's called balanced billing, or they might not. That's legal in some states it's not. You can understand why as a patient that can be extremely distressing to pay your surgeon, you know, $2,500 for a surgery and pay anesthesia $800 for a surgery and pay neuromonitoring $30,000, right? So the goal is never that the patient pays that, I think, but they get bills for that. So that's one of the problems behind the out-of-network billing thing. And you can imagine that if you are part of the ownership of that company that is billing the patient multiples of what you billed, or possibly even what the hospital billed, that can maybe not look great. So what I was getting at a minute ago is everyone will say, yeah, well, that's like the shady guys that do the shady stuff. But if I have like a conflict of interest and I own the company, like I'm going to tell the patient all about it and they'll know and we'll, you know, do what is right. And again, like that's great. But this here is, they looked at the 100 physicians in the United States that made the most money from drug companies and device companies. So the vast majority of these people were surgeons, and the vast majority of those were orthopedists and neurosurgeons. Out of those 100 people, they published 225 papers in this 1 year that they looked. And really, it was about 75 of them that published all of them, because about 25 didn't publish. In those 225 papers, only 37% of the time did the surgeon disclose a conflict of interest they had with a company that was directly related to that paper. And that 37% came from people looking back at the ProPublica data and seeing who they were getting royalties from. And we're not talking about a cup of coffee here. We're talking about these are the 100 highest earning physicians in terms of money from companies. So in my mind, if I'm going to publish something that's peer reviewed, and 2/3 of the time, I'm not even going to disclose that I have an interest in this thing that I'm talking directly about, what does that say about what I'm going to say to a patient where there's no watchdog, there's no way to see what rate I'm actually talking about? Like, it's probably the same or worse. And I'm not accusing anyone in particular. I'm just saying we need to be aware of our own inefficiencies and inadequacies. And part of it as physicians is that we're maybe not great at declaring conflict of interest as a big group as we think we are. And this kind of shows this one particular example. And I think even in this example, we think of devices a lot. We might not think of some of the ancillaries or the pods, like Dr. Hisey was saying. We had a thing in place at Texas Back where they would kind of do that. If it's smaller, if it's a smaller group, it's probably easy to let that slip through and not think about telling patients, oh yeah, I'm using neuromonitoring company A and I own part of that, and I forgot to tell them I own part of that. Not to mention the fact those patients are typically consented for neuromonitoring right before the case. They might not even know before that moment what neuromonitoring is. So all of that kind of together to say it's only bad if, obviously, if you're committing fraud, it's terrible, but then if it leads to improper use. So is there regional variation? Absolutely. You know, when I did my residency in New England, nobody neuromonitored anything. When you go to Dallas, everyone neuromonitors. That's the regional standard of care. If you don't neuromonitor in Dallas and something bad happens, the first question you're going to be asked is, why weren't you neuromonitoring to protect the patient? That's just the reality of it. Training and comfort level has a lot to do with it. If you're used to neuromonitoring cases, you're probably going to neuromonitor cases when you get out. The big question that there's no great paper on is, are you more likely to neuromonitor a case if you have an interest in the company than if you don't? You would think, because there's evidence of that happening with devices that people have interest in, and with pharmaceuticals that they have interest in, we know they use more of them. And there's a reason we can't put a drug company name on a pin anymore. It's because it makes doctors prescribe more of that drug for, you know, take that for what it's worth. So there's probably some element of that here. And then there's just general improper use. Should we be using neuromonitoring for a kyphoplasty or for an epidural steroid injection? I mean, most people are going to say no, but those things happen occasionally. And who's going to control whether or not they continue, and who's in charge of making those decisions? And, you know, there's really no great answer for that right now. So that's pretty much the neuromonitoring stuff. So Dr. Hisey had a chance to get a drink of water, and we'll turn things back over to him.
I sure did. Thanks. So I'm going to talk a little bit about surgical decision making. And when we're making decisions, there are often several alternatives that we might consider for treating the same disease process. And there's very reasonable discourse about this. And this is why we have papers on things. There are almost always advantages and disadvantages to the patient of each alternative. There's different risks associated with different procedures. There's different recovery times. There's different rates of recurrence, and there's different rates of adjacent segment disease, or, you know, risks of recurrence at the same or a different level. And the cost may be different. The patient's out of pocket, or at least what the insurer has to bear, may be different. And there also may be advantages and disadvantages for the surgeon. There's maybe a more difficult way of doing something, or a way that they're more trained in or more comfortable with that is better for them. There may be a different recurrence risk for them too, and that may affect how they're perceived in the community. Well, this guy always has recurrences, this guy never has recurrences, therefore it's an advantage to do a procedure that has less chance of recurrence, to me, at least in terms of my community perception. And then, of course, the big elephant in the room is the reimbursement. Some procedures we get paid more, and people, you know, doctors are people too, and people are motivated by money sometimes. I'm going to try and bring out these differences with a few very straightforward cases. I don't think there's going to be a lot of controversy about the cases, and that's not what I'm trying to bring out in these cases. They're not. I don't think they're controversial, but we'll see. Didn't go forward. First case is a 41-year-old female OR nurse with severe left C6 and C7 radiculopathy. You know, the pain where you'd expect it to be, neurologic findings like you'd expect. She did have a reasonable course of non-surgical care with 6 weeks, even in a collar. She had a Medrol dose back. She even had an epidural steroid injection. I don't know that all of them get that. These are pre-op images showing some, you know, the not atypical degenerative changes in the cervical spine, probably worse to C5-6. And this is her MRI showing herniations at both 5-6 and 6-7. And I don't think that this is a controversial surgical candidate. And there are a couple things you can do for this patient, all of which might be reasonable. So the options might be ACDF, maybe a 1 level. You might say, I'll just go after the worst level, or maybe a 2 level. I think most people would lean towards 2 level, but you know, I think either one might be reasonable. For amyotomies, if you thought you could get to those herniations, I deliberately picked a case with more central disc herniations that would be harder to get with a foraminotomy. Arthroplasty would also be a reasonable option for this patient if that's something you're facile with. So how does the surgeon make these recommendations? And let's all assume for the sake of this discussion that we all agree that both levels need treatment. And we may not both agree on that right now, but just for the sake of argument, let's assume that. So I did kind of an advantages and disadvantages of each procedure. And I listed it, you know, what's good for the patient and what's good for the surgeon, and they don't always align. Sometimes, like the advantages of ACDF are long history of success. Well, that's maybe advantageous to the surgeon, but I don't know the patient cares about that. They want what works for them right now. Better reimbursement, certainly better for the surgeon. Learning curve complete. Some surgeons haven't had the ACD or arthroplasty learning curves. The surgeons almost certainly have an ACDF learning curve complete. Foraminotomies are better because faster healing, doesn't limit future options. Those are both better for the patient, and they're, you know, potentially an advantage for the surgeon as well. Arthroplasty has faster healing. Surgeon may not be as sensitive to that as the patient is. Less adjacent segment disease, again, the patient's going to be more sensitive to that than the surgeon. Lower chance of all-cause reoperation. And again, the surgeon may be sensitive to that if they don't want the reputation of having to reoperate on people, or they may like having to reoperate on people because it keeps them busy and it's an annuity. And then disadvantages go the same way. And I'm not going to read through all of these, but you know, some of the differences definitely favor the surgeon. Some of the differences favor the patient, and they're not the same. They're not sensitive to the same things. And I did not include the other player in this, which is the insurance company, and that could come into it as well. But I think most of the time we're not making decisions based on how it's going to affect the insurance company unless the insurance company is saying no. So now assuming the patients are an equal candidate for each procedure, and some of these might be advantageous if a patient is a candidate for one or the other. Like, for instance, you can't address some pathologies with foraminotomies. Well, we're assuming they're equal candidates for all the procedures, so we're taking that off the list. Doesn't address neck pain. Well, the patient's an equal candidate. We'll take that off the list. So, but you're still left with some things that even if the patient's an equal candidate for all of these, might be decision makers. Now, I borrowed this from Dr. Bervin. Took it right out of one of his slides unabashedly, and he has a way of presenting the cost effectiveness of new technologies, and he runs a line of clinical equipoise on the chart, which says, okay, we have the cost versus the effectiveness, and if the cost is higher and the effectiveness is higher, that's in the kind of an area where you can maybe make a decision to use it or maybe not. If its cost is high and the effectiveness is low, of course it's something that you would reject, and if the cost is low and the effectiveness is high, of course, it's something that you would accept. So can you use this way of thinking to make a decision about how to treat a patient? And I think, well, maybe you can. So I looked at what's good for the surgeon and put better up higher and the surgeon on the vertical axis, and what's good for the patient on the horizontal axis. I said, okay, each procedure is going to fall somewhere on that, and it's going to be important how one procedure falls relative to another procedure. I don't think we're going to agree amongst ourselves where any particular procedure fits on this graph, but hopefully we can agree on how one fits relative to another. And this is the line of clinical equipoise, as opposed to the financial equipoise, where clinically the patient is just as good if the procedure falls on that line. The patient is just as good with either treatment or however it falls on that line. And that line doesn't have to be right in the middle of the chart. It could be anywhere. So if the treatment, the two treatments being compared are right above one another or right below one another, that's a line of clinical equipoise. It's very, the patient is not affected by it clinically. So similarly, if you look at the quadrants, in the quadrant where it's better for the surgeon, better for the patient, it's easy to decide to offer that treatment. It's always better for the patient and better for the doctor. We're not in conflict. Everything is good. In the lower left quadrant, it's easy to decide not to offer that treatment, to offer the baseline treatment, because it's worse for the patient and worse for the doctor. We're on alignment. But there, in the other two quadrants, where it's better for the surgeon and worse for the patient, or better for the patient and worse for the surgeon, we're put at odds. What's good for us is not as good for our patient. So we've got to keep in mind, we got to offer something that's hopefully good for the patient. We need to prioritize the patient. I'm not sure that's always done. These lines are all lines with positive slopes. So in each of these cases, if the two procedures you're comparing fall on one of those lines, your incentives are going to align with the patient's incentives. So lines with negative slopes, though, where you're connecting in the opposite direction, your incentives are not aligned with the patient. So how could this be used? Well, we put the standard procedure at the center of the graph and then placed a new alternative procedure somewhere on the graph as well. This first example I'm going to present is where the alternative treatment is better for both the doctor and the patient. It's easy to decide to offer this treatment to the patient. So if you fit this on the graph, easy to decide. Now, if it's the opposite, the alternative treatment, the new treatment, is worse for the patient and worse for the doctor, it's easy to decide not to use that. But in the cases where the alternative treatment is worse for the doctor and better for the patient, or better for the patient and worse for the doctor, you're going to find conflict. And what will happen, I think, in some cases, is the doctor is going to try and this is what's called perverse incentives. Our incentives are not aligned with the patient. We're incentivized by the game. Don't hate the player, hate the game. We're incentivized by the game to do what's best for us, not what's best for the patient. And that's not really the way it should be. What we'll do is we're thinking about these things. We'll try and say, well, this procedure is really just as good for the patient as the other procedure, and I might get a little bit more. So what you try and do then is you try and move them towards the line of clinical equipoise. And the doctors will do this to the data. They'll just move it towards the center. So now they're in a place where, well, these procedures are just as good for the patient, and so no harm in me choosing what's best for me. And I think we will fudge our thinking about the procedures in some ways to make things better for ourselves. So back to the case I started with. Where do we put these procedures on the graph? And again, where they are specifically on the graph isn't important. It's how they sit relative to one another. ACDF is certainly better for a surgeon in terms of reimbursement and no recurrence risk, that sort of thing. Arthroplasty is certainly better for a patient in terms of no reoperations at the same level, faster recovery, less adjacent segment disease. And a foraminotomy is somewhere in the same region where it's very quick recovery, good for the patient, no adjacent segment disease risk or minimal, certainly shouldn't alter it compared to a baseline. So this puts us in a position where the incentives of the patient is not aligned with the incentives of the surgeon. So how do you make that decision? Well, in this particular patient's case, I decided to do an arthroplasty. I thought that was the best thing I could offer her. Less chance of recurrent disease, less chance of adjacent segment disease. So that's how I think about these things when I'm trying to make a decision. She did well, and I know I'm running out of time. I had another case to present, which is even quicker. This is a guy that has a lumbar disc reherniation. And I'll tell you, the options might be a fusion, might be a revision discectomy. The fusion, definitely advantageous to the surgeon. Obviously, fusions have disadvantages of the patient in terms of recovery length and adjacent segment disease. A revision discectomy has advantages of being a smaller procedure, quicker recovery, but there is a recurrence risk that is not present in a fusion. Fusion is not going to have a recurrent disc herniation. And the treatment for a second time revision might be a fusion anyways. So, but again, the patient may not be, their incentives may not be aligned with our incentives. I did do the revision discectomy. I thought it was better for the patient. There is a risk that it could come back. That has not been prevented, but I think at least we allowed him to have at least a trial of a smaller operation. This, I think, can be applied to any surgical decision-making where you're talking about things like same-day surgery versus stage surgery for degenerative cases. We see cases where a small part of the procedure is done one day, brought back the next day, so you get that first code again. Definitely better for the surgeon, questionably better for the patient. I understand stage surgeries for deformity are a completely different story. Buttress place for ACFs, or for A-lifts, does that help the patient? For a lateral approach, does putting a plate on help the patient? I'm not sure. Definitely helps the doctor because they get an extra code. Corpectomies versus discectomies. We see a lot of partial corpectomies on cases where the procedure might have been just the same as a discectomy. Stem cells, interspinous devices, are those better for the patients? Are they better for the doctors? Are the incentives aligned? Anyways, I think you can think about a lot of things this way, and I think it's a fun and interesting way to look at it. I'm going to conclude now, and ethical decisions are really baked inextricably into what we do on a daily basis and how we make our decisions, even though we may not think of them that way. We're making a choice that has some ethical implications, however we make our decisions for our patients. Awareness of this can allow us to manage these conflicts and allow us to make the best decisions for our patients. It is our duty to advocate for what is best for our patients, but our job does not always reward us for that. Our job is making money, that's the job, but our duty is to take the best care of patients. And as Rick said in his myths of spine surgery talk, keep the patient first and use the family test. I think you can't go wrong if you do that, if you keep the patient first. thank you. And again, thanks to Seattle Science Foundation for having me.
Mike, that was terrific. Hey, Jens, any final words you want to say to everybody, or Sig? Sig, why don't you say something?
You're muted, Sig.
Yeah, terrific job, Mike. Absolutely an important topic and really well presented. I like the framework that you came up with regard to matching and aligning incentives. I think in many ways, some of the advantages, some of the alternative payment systems are by sharing risk. We do align incentives. When there's a disassociation of the perceived risk or the perceived cost and the perceived benefit, that's when perverse decisions are made. I loved your examples, and I think that this is a topic that really requires a half-day symposium for some discussion. So really well done, and thanks for such a thought-provoking topic.
Thank you, Sig.
Jens, final word? Jens, you're muted.
Doesn't look muted.
Hello?
Yeah, we can hear you now.
I should not be muted. Can you hear me now?
Yeah, we got you.
I can't hear you guys now, so this is crazy. So this was a whole instructional course lecture in, or a whole afternoon or morning session at NAS in 1 hour. Congratulations. I mean, my head's spinning. I'd love to talk and review every single thing from research, ethics and research down to billing and neuromonitoring. So thank you. Thank you for a thought-provoking session.
Well, Mike, thank you very much. I know you put a lot of time into this talk, and I know you were worried about it, but it came out great. And thanks, everybody, and have a good evening, and we'll see you Friday.
Appreciate it.
Thanks
Have a good
again,
night.
Mike.
Please see the chat box and the slide to claim your CME credit. You have 2 hours post-course to claim your credit. 2 hours. Thanks, everyone. Incredible program today.
Oh, thank you. Great job, Mike.
Thanks.
Nice job, Mike.
Thank you, sir.